For our final project, myself, Jennifer Swain, Sarah Stevens, Tommy Joyce Richards, and Tracy Masker decided to take a look at the healthcare industry, what the current state is, what the challenges are with transformation, and what our future recommendations would be for the industry as a whole. So looking at the current state of healthcare, largely reimbursement and physician compensation is tied to volume. So essentially keeping patients in beds, ordering additional studies, and increasing treatment plans. Looking at GDP of healthcare, it makes up 18% of our overall GDP, which significantly outpaces inflation. And then looking at the graph there on the right, you can see that compared to our, what you'd consider peer groups, we're drastically ahead of them in terms of overall GDP. Another study showing the current state on a per capita basis for comparable countries, we're significantly ahead on a per capita basis on healthcare expenditures at $10,224. So now moving forward to the transformations at high level. Government, business, industry, patients, everyone kind of came together and realized that transformation needed to take place. And so looking at the triple bottom line, there's key parts of that. So on the people side, improving patient experience, the planet side, improving population health, and then reducing per capita costs on the profit side. And as you can see there on the right-hand side, the triple aim of healthcare was created in 2007 when this transformation kind of began, and also, outlines or is in sync with the triple bottom line listed on the left there. Looking at the transformations in more detail, on the payment structure side, originally and in the current state, it was to keep people in beds, run more studies, perform more procedures, and thus receiving revenue from that increased volume. In the transition phase, the idea is more on the preventative side, keeping people out of those beds, using less studies, and kind of getting things right the first time. Looking at the health system cost structure is another major transition. So looking at technology and medical devices, there's a lot of new products and procedures out there that, in the imaging space and non-invasive space that are highly expensive but are touting that they have, increased clinical outcomes. And so moving forward, this will lie within the health systems, the payers, suppliers to kind of evaluate what that kind of cost benefit is. And then lastly, the utilization of data to make kind of uniform clinical protocols so that all providers within a healthcare facility are having uniform treatment plans and that the supply cost is in line there. And then additionally, utilizing data to better understand what the population is from a population health standpoint, and then also utilizing that data to better create treatment plans and have a better understanding of what the treatment needs to be for chronic diseases. And I'll hand it over to Sarah to cover the challenges and then our recommendations.
Thanks, Drew. As Drew said, this transformation in healthcare really started in 2007 and was supported with the Affordable Health Care Act in 2010. And as you can see, we've made a lot of progress. This shows the annual growth in healthcare expenditures. We used to dramatically outpace other countries. We've been able to drive that cost increase down, and even in some of those years do better than the countries we compare ourselves against, but it's really insufficient. As you noticed from the original slides, our cost per capita of healthcare still outpace our peer group countries. So what are some of the challenges? Payment models need to change. Health systems are not going to change to focusing on quality and doing less care while they're still being paid on volume. And then, there have to be adjustments in the healthcare population. Certain populations are more sick, and it's hard as you look at how to pay for quality. Is it that certain maybe inner cities are utilizing more resources inappropriately, or are they just a more sick population? These are some of the really tough things that have to be wrestled with to totally transform the payment system in healthcare from volume to value. We also have to develop metrics to measure quality. Quality is a pretty qualitative thing. It's difficult to define and then quantify if outcomes align with costs. And this can be really socially sensitive. If you're, what cost is too great if you're talking about your child? This is a tough, just a tough societal challenge. A couple other challenges, we have to change the mindset of patients. How much of the cost is driven by chronic disease and conditions like obesity? We as patients have to flip the script and start thinking more about health than sickness. Reduced antibiotics, that's something patients expect antibiotics every time they go to the doctor's office with a cold. We have to be comfortable with saying, hey, it's a virus and those antibiotics aren't going to help you. And then treatment plan compliance. If patients with those chronic diseases need to follow the recommendations of their physician and really, again, focus on health. We also have to change the mindset of physicians. They need to focus more on prevention and health and less on volume. And that's just, they're in the habit of driving volume. That's what they've been doing for years. So that's a tough transition as well. So what are some of our recommendations? As we discussed the Mastering of the Cube book, we were really surprised by how well this concept of alignment really worked. The first thing we have to do is improve the ability to measure quality and costs. As Peter Drucker says, you can't manage what you can't measure. It really comes down to we have to figure out how to manage those qualitative things and measure quality and really rely on that data and make decisions based on it. So then the next side of the cube, you use that information to adjust workflows. And this is everything from physicians following protocols for common issues, and this drives quality in a way that's measurable. If we have everybody doing the same thing, if somebody comes in with asthma, they follow the same treatment plan. And we need to break down the silos and create alignment between the various aspects of healthcare, from operations to clinicians to administration to supply chain, etc. And simplify, collaborate, and again create that alignment. We need to design incentives around encouraging quality care rather than volume. And we also need to be transparent with our data. We have to show physicians, hey, this device, implant, supply, protocol really drives favorable outcomes for your patients. And physicians at their core are scientists. They understand data. We have to be transparent with that data and incentivize behavior change. On flipping to the next side of the cube, valuing people who provide highest quality. Leadership really needs to drive home the message that we're an organization focused on quality. We're not focused as much on volume. I mean, there's a transition period to that while the payment models are changing, but leadership has to drive the message that it's about quality and cost control. Under the continuous improvement side, it's really using that data and workflows side of the cube to keep revising and working it. What is the data telling us? How can we revise our workflow to drive those metrics in the direction we want to? And then finally, disciplined decision making under governance and structure. We have to perform cost-benefit analysis before investing in new technologies, new devices, and we also need to hold people accountable to the assumptions and projections that they make. So if they say, this expense will generate XYZ results, leadership and the governance structure needs to hold people accountable to those assumptions and those results. So with that, here's our source slide. Thank you very much for your time.